Hello, everyone. We'll just let everyone join. Just give a minute or two. Welcome to EPI-WIN. Just another minute to let everyone in. Right. I think we can begin now. So good morning, good afternoon, good evening to everyone. We welcome you all, particularly those of you joining from far away or late or in the early times. I'm Supriya Besbarwa. Thank you for joining this EPI-WIN webinar. Today, our topic is Clinical Practice Guidelines for Influenza, New WHO Recommendations and the Evidence. For those of you who are new to EPI-WIN, it stands for the WHO Information Network for Epidemics, for Science and Knowledge Translation in Health Emergencies. Our goal is to translate science to make it accessible, understandable, and relevant for evidence-informed actions and decisions in health emergency preparedness and response. So today we have a really eminent and distinguished panel of speakers. We have Dr. Janet Diaz, who will provide the welcome and introduction. She's the unit head of clinical management for WHO Health Emergency Program. We then have Wenqing Zhang, who's the lead for the Global Influenza Program. And for those of you in influenza, she needs no introduction either. Then Tim Uyeki, who's the Chief Medical Officer in the Influenza Division in US CDC, will talk about the PAHO experience, especially H5N1. He's also one of the chairs of the guideline development, the WHO guideline development. After that, we will have Dr. Steve McLaughlin, who's a consultant clinical management unit consultant in WHO, and also an intensive care and infectious disease physician from Australia, will give the overview of the recommendations and the new guidelines. And if you have questions, the other co-chair for the guidelines, Yi-Sin Liu, who's the Executive Director for the National Center for Infectious Diseases in Singapore, will also be answering questions. We have Jamie Rylance, who will moderate the Q&A session. And for the EPI-WIN team in the background, we have Sophia Song and Konika Sachdeva from ECHO India. Without any further ado then, I will hand over to Janet, but just before that, some housekeeping. This webinar is being recorded, and afterwards the recording will be made available from our website, as will the presentations in PDF format. Those of you who are veterans of EPI-WIN will know this already, but we'd love to hear from you. We'd love to know about you. So please write your name, location, and organization in the chat box. We'd love to hear where you're joining us from. But please do not add your questions in the chat box. If you have questions, put it in the Q&A box. That's because we can miss the questions in the chat amidst all the introductions, whereas the Q&A box, we will not miss it. So please, questions in the Q&A box and your name, location, and organization in the chat box. Without further ado, then, I will hand over the floor to Dr. Janet Diaz, Unit Head for Clinical Management in WHO. Over to you, Janet.
Thank you, Supriya, and good morning, good afternoon, good evening, colleagues. It is my great pleasure to welcome you to this EPI-WIN webinar, the session on clinical practice guidelines for influenza virus infection, and on behalf of the Health Emergencies Program here within WHO. I don't probably need to remind you of how important it is to have how important it is to have strong pandemic preparedness and response strategies and plans within your hospital, if you're a clinician, within your jurisdiction, if you work for the Ministry of Health, within your country, and within your region and around the globe. So as part of WHO's Global Health Architecture for Health Emergency Preparedness, Response, and Resilience, there is one important capability which we're focusing on right now is the delivery of safe and scalable clinical care. And so what does that mean? That means that we can treat patients during health emergencies with effective and safe treatments. So part of the work that this unit does that I lead, and the colleagues that are on the call are with me, is we focus a part of our work on developing clinical practice guidelines for different pathogens, for different emerging or re-emerging infectious diseases, and influenza is one of those. And my colleague, Dr. Zhang, will go in more detail about the epidemiology of influenza virus infection. But if you simply look on our website, you can see there's about an estimate of 1 billion cases of influenza seasonal disease a year across the globe. That leads to 3 to 5 million severe cases due to influenza virus infection, and nearly an estimate on average 500,000 deaths a year. So the burden of disease is high. So what we are aiming to do today, which was an update to a previous guideline, is we took the usual approach that we have been taking for clinical practice guidelines and recommendations, where we look systematically at the evidence, so see what clinical trials have been done on the topic, looking at clinical interventions. Then we synthesized the evidence and went through a rigorous process to develop grade-based, transparent, trustworthy guidelines for treatments for influenza virus infection. And in that process, we then developed the guidelines that we're going to present to you today. I think what's novel about, what's important about this new guideline is that it's increased in scope from the previous guidelines. We will describe recommendations that have been formulated both for mild, non-severe influenza virus infection, as well as for those with severe influenza virus infection. We will talk about treatment of seasonal influenza virus infection, as well as treatments of avian or zoonotic influenza virus infection. So that's also very clearly delineated in our new guidelines. And we will also talk about prophylaxis for people who have been exposed but are not yet symptomatic, as well as the use of diagnostic testing in the clinical care pathways of patients being evaluated with acute respiratory infections. So before I hand over, I want to say this guideline, which is very robust and a bit long, is made out of a massive collaborative effort between many experts around the world. So a big thank you to all the guideline development group panelists who spent many hours preparing, attending our meetings, and helping us formulate these recommendations. A big thanks to our co-chairs, Tim Uyeki and Yisin Liu, who are on the call today for again, extra hours they spent helping us deliberate on these recommendations over the past year. And a big thanks to the MAGIC evidence ecosystem, specifically Professor Gordon Guyot, who helped us methodologically review, synthesize, grade, assess, and develop robust recommendations. So it is with that I thank you for attending this webinar. I wish us all a good session, and look forward to the Q&A, and hand off now to my colleagues to go into detail about this clinical practice guideline on influenza and how important it is to get this out there so that we can all best care for our patients with influenza virus infection. Over.
Thank you very much, Janet, for that introduction and providing the backdrop to the guidelines and how it came about. Before we go on to hear more about influenza, we'd love to hear from you, the audience. We'd just like to know a little bit more about you. So here's a Slido. You know the drill now, those who are regular with it. If you can go to slido.com, and it's hashtag 2930989. That's 2930989. And if we just want to know about your background and experience, are you a healthcare worker? working on influenza. Just it looks like the majority of you are. Great. So it looks like most of you do work on influenza. Fantastic. So this is very relevant for you. And for those of you who don't, I hope you still learn something interesting, which will broaden your horizons. I will now take this off screen, but I'm leaving the Slido poll on so you can join anytime and vote there. Slido.com, hashtag 2930989. And now I would like to invite Dr. Wenqing Zhang, who's the lead for the Global Influenza Program at WHO, to provide an overview of the program with a focus on seasonal influenza. Over to you, Wenqing.
Thank you, Superior. Would my slides be shared? Wonderful. So first of all, it's great to see many healthcare workers working on influenza connected in the webinar. Hello to you all. My task today is to give an overview of the global influenza program focusing on seasonal influenza within 9 minutes. So let me set the timer on. Next slide, please. So we all know that aquatic birds is the reservoir of influenza viruses. So there are many influenza viruses in the aquatic birds, in animals. These are called animal influenza. Some of the viruses jumping out cross species to infect humans, like H5. We'll also have an update on H5 as well. These viruses are called zoonotic influenza. And then still some of the viruses developed into efficient human-to-human transmissibility and then causing a pandemic. Those influenza viruses are called pandemic influenza. But today we are going to talk about seasonal influenza. That's my task. This is the influenza virus circulating year-round and causing seasonal epidemics in human population. Because of the unique feature of influenza viruses, they need to have a global approach to monitor, to prevent, and to control seasonal influenza, and of course, also for the zoonotic and the pandemic influenza as well. Next slide, please. So the awareness of such need was developed a long time ago. And this was actually the start of a global system. Many of countries at the moment, as shown in the map, belong to. It's a global influenza surveillance and response system. It's been functioning for more than 70 years already. And this system, GISIS, has been coordinated by the Global Influenza Program that included in my title of this talk itself. Next slide, please. So the functioning of this global surveillance system is on evidence, is on data, is on year-round function engaging many member states. And so far we have more than 130 member states formally joined this. In the past 70 years, the capacity and the capability has been evolving and strengthening over the years. Just to make a point is that the difference of this network from other network is because the capacity and capability are live. They are functioning year-round to dealing seasonal influenza, but also zoonotic influenza as well as pandemic influenza. Next slide, please. So this is a glimpse into how this system has been functioning, because this is a base of the data I'm going to show you later on. This is based on the year-round surveillance. The chart shows the number of specimens tested by this global system. And we can see that in the recent years, the number of specimens tested by the global system has been increasing tremendously. Like the last year, 2020, 2023, actually were more than 10 million specimens tested for influenza. So through this, we, WHO, jointly with the people in the world, will be able to monitor influenza closely. Next slide, please. So this slide shows the seasonal influenza in the past 10 years. Of course, the data has been based on the surveillance I just very briefly introduced. So from this chart, we can see that actually seasonal influenza, it truly is seasonal, as you'll be able to see the different peaks over the years. And also from different color, we will be able to see that there are different types or subtypes of influenza, seasonal influenza actually virus circulating, and they are changing from season to season. And also for different seasons, some of those are more severe or circulated at a higher level, and some of those at lower level. Next slide, please. So let's zoom into a little bit since COVID-19 pandemic. And we know that because of the emergence of SARS-CoV-2, seasonal influenza actually was disrupted, as you can see here, very low, the positivity rate as drawn here by the blue curve here. But the point here is that since 2022, later 2022, the usual season pre-COVID pandemic comes back. Next slide, please. So through this global system GISRIS, we would also be able to monitor the co-circulation of SARS-CoV-2, because it's all respiratory viruses. We need to monitor at the same time for countries to make a decision. The red curve pictured here actually is the percent positivity of SARS-CoV-2. One point or one observation we can have is if we look at the peak after COVID-19 pandemic, is that since COVID-19 SARS-CoV-2 peak and the influenza peak, they are not really overlapping. But still, we would need to see how the seasonality of SARS-CoV-2 is going to be established. Next slide, please. So what is most interesting, of course, is the current. And this chart shows since September last year, the seasonal influenza situation, Northern Hemisphere and Southern Hemisphere there. Those bars colored in blue are influenza A, H1N1, H3N2, and those in brown or orange are B viruses. From the chart, we can see actually the peak of the timing are different. And also the proportion of the circle or different subtypes are also different. But in general, is influenza A viruses certainly predominant in both hemispheres since September last year. Next slide, please. So this is a type of dive into the actual situation in different transmission zones. And the first one is from February to August this year, and the right side is from September 1st to October. And actually, the current situation, as we've seen from the right side of the map, is like in West and Central Africa, there's activity going on with influenza H3N2 virus predominant, while in South Asia, we can see that there are activities also going on, but with the predominant of H1N1 PDM of 9 predominated. But in general, the seasonal influenza at the moment is pretty quiet or low. Next slide, please. So seasonal influenza, as Janice at her opening remarks already mentioned, is not a usual thing or it's typo or normal thing. Actually, it kills. It can kill up to 650,000 respiratory deaths. Respiratory deaths, it didn't include like cardiovascular deaths, etc. It didn't include those. And also, every year, 3 to million severe cases that would require hospitalization or even death. Next slide, please. So aside from the clinical management that this webinar is going to move on, there's also influenza vaccines available. And I listed here is the risk groups recommended by WHO SAGE in 2022. Healthcare workers, individuals with comorbidity and underlying conditions, older adults, pregnant women, and in countries with resources available, countries can also consider additional subgroups, for example, children. Next slide, please. Because of the influenza virus is constantly evolving, those components contained in seasonal influenza vaccines also need to be updated. So this chart shows that actually how every year the components are being updated through year-round surveillance and working together with partners from both private and public sectors. Next slide, please. So just to highlight for the upcoming Northern Hemisphere, which is about to start, this is the composition of the influenza for influenza vaccines for use in the Northern Hemisphere season. There's trivalent recommendation, but also the quadrivalent vaccines available. Next slide, please. So to highlight that WHO's approach to influenza is not just only seasonal influenza, but also a whole spectrum of the aspects of prevention and control of influenza, as shown here, as pictured by a WHO Global Influenza Strategy, which was adopted in the World Health Assembly in 2020. Next slide, please. This is my last slide, just to show that there are a lot of resources, materials available from WHO's website here. We also have an email address available. Please don't hesitate to contact us. And also, last but not least point is that with the Northern Hemisphere influenza season starts, it will be highly recommended if you belong to the risk groups, get influenza vaccination done. Let me just stop here and hand over to Janet or to Supriya.
Thank you for that overview of influenza and the final message that it's time for vaccination. I will now request Timothy Uyeki to talk about the experiences in the PAHO region, the Pan American Health Organization region, for those of you who are not familiar with the WHO acronyms. He's also the chair of the guideline committee that developed these guidelines. So over to you, Timothy.
Yeah, thank you. May I have the first slide, please? Great. Right, so I was asked to speak about human infections with highly pathogenic avian influenza A H5N1 viruses, and I'll try to give a brief global update and mainly focus on experience in the Americas. Next slide, please. So what I'm talking about here are sporadic novel influenza A virus infections. These are human infections with this H5N1 virus, and the source of H5N1 viruses is in wild birds with spillover to poultry, but also to other animals, and I'll talk about that briefly. So the first time we heard about human infections was the Hong Kong outbreak in 1997 with 18 cases and 6 deaths, wide age range, and these infections were traced to exposures at live poultry markets in Hong Kong. We didn't hear much for a while, and then we started hearing about human infections reemerging in 2003 and primarily over the next couple of years in China and Southeast Asia. But since 2005, there have been cases identified in many other regions of the world. So the global update as of yesterday is since 1997, 942 sporadic cases with about 50% case fatality. So this is a pretty lethal virus infection. Cases have been reported in 24 countries. Most of these cases have been sporadic cases with pneumonia in children and predominantly in young adults. I just want to say that these viruses continue to evolve, and they're evolving and spreading in wild birds. And there are some regions of the world in which these viruses are spreading among poultry. And we have these poultry outbreaks, and also many different animals have been infected in different regions of the world. And so we classify these different genetic groups into what we call clades. And I'll just talk about in the next several slides about different infections. But I don't want people to focus too much on the differences in the clades, just to say that this virus can cause a wide spectrum of human infection, including critical illness and death. Next slide, please. So this is an epidemic curve of human cases since 1997 to date. And what you see is, particularly in the middle of the slide, many different cases in different colors. There's a different countries. But since the large outbreak in 2015 in Egypt, very few cases. And then to the right, over the last couple of cases, an increase in human cases, including in different regions of the world, including in the Americas. Next slide, please. So how do people get infected? The risk factors for human infection with H5N1 virus, almost the vast majority of cases are attributed to exposure to infected poultry, either direct or close unprotected exposure to sick or dead backyard poultry in rural areas. Also, visiting a live poultry market is a risk factor. There have been a very small number of cases whose source of infection was attributed to exposure to infected wild birds, defeathering wild swans. There are some cases with no known source of infection, but in 2024, for the very first time, we've had human infections resulting from exposure to infected mammals. And in the US, we have had the first cases of dairy cattle to human transmission, and I'll talk about that briefly shortly. And then I just want to mention what we're always concerned about, but it's been very rare, fortunately, which is limited non-sustained human-to-human transmission. This has not been reported since 2007. It's always something we're very concerned about because we're very worried about the next influenza pandemic. So there's currently no sustained transmission of H5N1 viruses and no limited non-sustained transmission since 2007. Next slide. So I'll just talk about some of the US cases. This is cases over the last 2 years. We've had 28 human cases to date, and there's no question we will be identifying more cases, including likely this week. 27 of these cases have been identified this year. We have had no secondary transmission to close contacts. 10 of these cases have been associated with poultry exposures. 9 of them this year were in people who were depopulating poultry, so confirmed commercial poultry outbreaks. 9 of these, all of these cases were mild conjunctivitis cases. A few had respiratory symptoms as well. They were all either treated with oseltamivir or offered oseltamivir. They've also used post-exposure oseltamivir prophylaxis to close contacts. And people who were asymptomatic were exposed to H5N1 virus-infected chickens, but had not yet been symptomatic. None of these cases were hospitalized. They all recovered. Then we've had 17 cases associated with dairy cattle exposures. These were all in people working with dairy cattle on farms. And just to note that we have had an ongoing multi-state outbreak of H5N1 virus in dairy cattle, 14 states in the US, more than 320 confirmed dairy cattle farms. So a lot of workers have been exposed, and we have had these sporadic infections. So 17 cases so far in 4 states. All of them except one had conjunctivitis. We had 1 case of acute respiratory illness. None of these individuals were hospitalized. They were all treated with oseltamivir. and oseltamivir was given as post-exposure prophylaxis to some household contacts as well. No secondary transmission. We had one case that was identified in a person without any known exposures to animals or sick persons. This was in a hospitalized person who presented after a syncopal episode. They had chest pain and diarrhea. So they had no respiratory symptoms, no evidence of pneumonia. They were hospitalized for observation. As part of the workup, influenza testing was performed. This person was identified with influenza A. They were treated with oseltamivir. They recovered after 3 days. They were discharged home. And H5N1 virus infection was confirmed after they were discharged home. It's not quite clear how they were actually infected. There was no secondary cases identified. It's a very puzzling case, but just to highlight that some cases do not have a source identified. Next slide, please. So just want to highlight there have been 2 cases in South America over the last couple of years. One case in Ecuador. This was in a pediatric case, 9-year-old girl who initially had upper respiratory tract symptoms and conjunctivitis. She also had gastrointestinal tract symptoms, nausea and vomiting. She progressed to pneumonia, respiratory failure, and septic shock. She lived in a rural area. She had exposure to backyard poultry that suddenly died. She was hospitalized on the 4th day of illness. She progressed, she worsened, she was transferred to a pediatric hospital in critical condition. She was intubated, and a nasopharyngeal swab collected as part of routine SARI surveillance was positive for H5. During the hospitalization, she was treated with oseltamivir. Fortunately, she recovered. There was no secondary transmission. Then in the spring of March 2023, in Chile, there was a middle-aged man who presented with respiratory symptoms, progressed to pneumonia and respiratory failure. It's not quite clear what his exposure was, but he lived in an area near the coast of northern Chile where there were large die-offs of seabirds and marine mammals, H5N1 virus infection. This man was hospitalized on day number 10 with pneumonia. He was initially tested for SARS-CoV-2 and was negative. He was admitted to the intensive care unit and on illness day 12, treated with broad-spectrum antibiotics and oseltamivir. Treatments was started empirically. The diagnosis of H5N1 was made on the 15th day of illness through a lower respiratory tract specimen, bronchoalveolar fluid specimen. And H5 was confirmed on day 17. He had a very prolonged hospitalization, but fortunately he survived and was discharged. And again, he was treated late with oseltamivir in the hospital. No secondary transmission. Next slide, please. And I just want to close and just say, although I've been focused on the Americas, cases in the US and South America, I'll just say that there's been ongoing cases in Southeast Asia, sporadic cases associated with exposure to sick or dead backyard poultry in rural villagers, wide spectrum of illness. A lot of these patients were not suspected with H5N1 until they were hospitalized with critical illness. There were missed opportunities for earlier treatment initiation with oseltamivir. Some of these patients were only diagnosed because of routine SARI surveillance at hospital admission. 10 of these patients had severe or critical illness and 6 died. In Cambodia, they've used also oseltamivir post-exposure prophylaxis given to close contacts, household members, and there have been no secondary cases identified. With that, I'll stop and I think turn it over to Dr. McLaughlin. Thank you.
Hi, I'm always jumping in ahead of Steve McLaughlin. I'm Jamie Rylance. I'm just going to ask a couple of questions for the Q&A that have been coming up through from the participants, and thank you very much for all of those. Just a question each, I think, to Wenxing and then to Tim, and thank you for your presentations. Wenxing, it's come up about the graphs you showed about the low incidence of recorded flu in 2021, and a couple of questions about the predictability of seasonal flu, both in terms of the numbers and how we use vaccines and try and match the vaccines to likely seasonal patterns. I wonder whether you could just talk for a minute or two about that.
Sure, of course. Hi. So thanks very much for this very interesting question indeed about the prediction. I think prediction is still being a challenge with regards to what's happening, especially in the next season, like in 6 months' time. It's very challenging. But a lot of efforts have been done because a lot of data from the surveillance are being generated. And the WHO, we've been really working very closely with modeling groups to understand certain disciplines that might be hidden under those data itself. But by saying so, it's still very challenging because of virus evolution. A lot of biological mechanisms of driving the virus evolution are yet to be researched, to be understood. So certainly that would impact on the models are being put together itself. AI, yes, I think this is a future, right? But where we're tilling now. So I do think it's a future, yes, AI could help, but now a lot of basic research, again, still need to be done in order that our models would predict more precisely or close to the reality of what's going to happen in the near future. Just to quickly comment on the lower circulation of influenza viruses during COVID-19 pandemic. So it might involve those virus at a viral level, the virus competition itself. And it might also related to the non-specific immune response in human bodies that the emergence of the SARS-CoV-2, a purely new viruses suppressed the circulation of influenza at that time. And yes, this is built on the true surveillance because the surveillance was not stopped at that time. So yes, so it did tell us that during that period of time, influenza virus circulation was low. Back to you, Jenny.
Thanks very much, Wenqing. Very clear. Tim, can I come to you? You talked about people that were at risk, particularly occupationally at risk from avian flu, and there's questions related to that in the chat, predominantly around vaccination and whether that's a tool that might be used and how that could be used to prevent zoonotic influenza spread.
Right. So thanks for the question. So just part of pandemic preparedness. There are many groups around the world as part of at WHO collaborating centers that are always working on candidate vaccine viruses in case there's going to be emergence of a pandemic virus. This is very true for H5N1 virus vaccines, but it's true for other novel influenza A viruses that are of pandemic concern. So we do have candidate H5N1 vaccine viruses or candidate H5 vaccine viruses that are a reasonable match for the H5N1 viruses circulating in poultry, spillover in wild birds, and spillover to mammals. So the question is whether or not people who are at high risk for exposure and infection might be vaccinated, such as poultry workers, and now in the US, such as these dairy cattle farm workers and so forth. So the only use of H5 vaccines that has been happening in the world is actually started this year in the European Union, and particularly in Finland, in people who work at these with farmed animals, such as Arctic foxes and so forth. And it's a voluntary program. It's a 2-dose vaccine. And they're also having eligibility for laboratory workers. As I understand it, there has not been a large uptake of this vaccine, but we really look forward to our colleagues in the European Union and specifically in Finland to let us know what their experience is going to be over the next, months to come and so forth, and particularly what the impact might have been, and so we look forward to really the story. But that's the only area of the world that I'm aware of in which H5N1 vaccines are being used to people who are exposed to animals that might be infected with H5N1 viruses. It's certainly under discussion in other countries, and I can tell you in the US, there have been discussions about utilization of H5N1 vaccines in different groups, but to date, we've not used H5N1 vaccines for anyone in the US. Thanks.
Great. Thank you, Tim. I think that's it for vaccines. We're going to move away from vaccines for the sake of time and into some clinical practice guidelines. So I'm going to hand over to Steve McLaughlin, please. Go ahead, Steve.
Thanks very much, Jamie. And if I could get my slides up, that would be great. Just while we're waiting, my name is Steve McLaughlin. I'm fortunate enough to be a consultant in Janet's team, the clinical management unit, and also an intensive care and infectious disease doctor from Australia. Just while the slides are coming up. No. Great, thank you. Thanks very much. So I'll go to the first slide. Look, this part of the talk, we just want to go through some of the major changes that were in the guideline. As Janet mentioned at the start, it's a long document with some pretty comprehensive guideline reviews, and I'll go through some of the significant changes first of all. Could I have next slide, please? And next one, please. Oh, next slide, please. That's great. So there was a guideline published in 2021, as was mentioned earlier. This was a narrower scope. So for this one, as Janet said, we've included both severe and non-severe influenza, and also some recommendations on antiviral medication to prevent influenza, which I think, as was recognised by Tim's talk, a real area of interest around the world. Next slide, please. I want to say thanks to everyone. As Janet mentioned, these guidelines only happen with a huge methodological and clinical input of literally dozens and dozens of people. So thank you to everyone who contributed, especially Tim and Yasin, who are on the call, who are kind enough to chair these guideline development groups for us. Next slide, please. So this one, it's a lot of information, but it's really just to demonstrate, and I'm an intensive care doctor, so sometimes we're a little bit simplistic. There is a flow chart at the end of the guideline that goes through the major recommendations, and we've tried to summarise in one flow diagram all the different treatment options. Again, just trying to keep it simple and a summary, trying to work towards that quick reference guide that clinicians often find quite useful. So if you can want to read the 250 pages, this is available at the end and potentially to give you a sign of where to go in the guideline. Next slide, please. One thing that was really interesting, and I guess I must admit to my naivety in this space, there hadn't really been, by WHO at least, a big attempt at systematically trying to work out what is the actual risk of seasonal influenza. Now, we recognise there's a lot of caveats to this. There's different strains each year, as working, and Tim has mentioned, obviously, I've got huge expertise in that area. But it was interesting. We had to initially estimate, as we worked out the guideline, well, what is the risk? Because if anyone, without boring people about the details of methodology for guideline development, what is the baseline risk of something? So what is the change you'd expect with a treatment is really quite important to work out. Fortunately, our expert panel were actually guesstimated very close to reality. And then we were able to convene a systematic review of observational studies, which was one of the first published attempts now at trying to work out what is the baseline risk of seasonal influenza. Recognising, please, this is for seasonal influenza. You'll see down on the third row there a little bit of different information. So for non-severe influenza seasonal, the baseline risk was about 1 in 1,000 for mortality. Once you develop severe disease, now for the purposes of this guideline and recognising the potential oversimplification that this implies, seasonal influenza was classified as people that required hospitalisation. There is a discussion about whether that's the best use of, what classifies as severe, but obviously it's a pragmatic and clinically useful definition. recognizing that the threshold for hospitalization and the ability to hospitalize people around the world is different. We did estimate the mortality from zoonotic disease. We've just heard a talk from Tim, which goes into the detail and the variability around zoonotic disease, but recognizing that it can be a highly lethal disease. And also a very important group, which is the risk of hospitalization from non-severe influenza at about 8 per 1,000. Next slide, please. The second thing we tried to look at was the risk factors for severe disease and death. So this was something that clinicians, including myself, had spoken about a lot when we see patients. Obviously, you see a patient in front of you and you wonder, is this person, if and when they develop influenza, what's their chance of dying? Obviously, a very patient-related outcome. There had been, again, potentially a lack of pooling of the observational data available. So with some colleagues, they were able to do a great study where they looked at observational data. And these large data sets were able to work out with those with an odds ratio of greater than 2, so a moderate certainty of evidence, what were major risk factors for developing severe disease and death in influenza. And immunocompromised, cardiovascular disease, neurological disease, and chronic respiratory disease. And none of these will particularly surprise people, but I guess it's nice to have the evidence behind what many people have been thinking. Other risk factors that had a significant odds ratio but potentially didn't quite meet that threshold included malignancy, pregnancy, and diabetes. So what we decided as a guideline group was a patient could be considered high risk for severe disease if they had one of the major risk factors or were 65 years or older. Next slide, please, and I can explain the age cutoff. It was actually quite interesting. So the odds ratio for every 10 years that a patient got older was 1.7. So really a significant impact of getting older, a real chance of developing severe influenza, And so you can imagine now as you get 30, 40, 50, 60, 70, the risk of severe disease goes up significantly. And based on discussions with the methodologists in our guideline group, 65 was decided as a cutoff based on the evidence. Next slide, please. And you'll see later when I talk about the prophylaxis question, that extremely high risk was defined as patients above 85 years old, again, taking into account that evidence we just talked about with a 1.7 odds ratio. And that declined to whether you with or without risk factors. So just being 85 placed you at significant or severe, extremely high risk, of severe disease. All patients that had multiple major additional risk factors, and that the clinician then determined that the patient was extremely high risk. We did leave some clinician discretion there, which I hope people feel is appropriate, but obviously we're looking at someone with multiple risk factors or one risk factor that's so severe that a clinician would think this patient's at extremely high risk of severe disease and death. Next slide, please. So then we got on to the recommendations. So again, without going through the complicated methodology, which is not complicated in terms of its determination, but just in terms of the process that's gone through in terms of it's an extremely thorough process where we look at, we use grade as a way of determining the strength of the evidence, and then an expert panel to make a recommendation. So what was interesting is that in patients, and this is why the high risk became severe. So if you think back to those risk factors I just talked about, patients at high risk of progression to severe disease, and you'll see in that little remark there, that's patients that are 65 years or older, or with one or more major risk factors for severe influenza. We suggest administering baloxavir. Now, conditional recommendations is second on the grading scale, I guess. Strong recommendation is a stronger recommendation, to state the obvious. So we suggest administering baloxavir based on the guideline group's recommendation for patients who have high risk of severe disease and who have non-severe influenza. Again, stating those are the patients that are not in hospital yet. You'll see also in the remark there about zoonotic influenza, so that they were not included in clinical trials. So that's challenging. And I think Tim explained well, when we look at the numbers of patients that have had zoonotic influenza, we can see why clinical trials have not been performed. So we also would suggest that evidence will also apply for this population. So if you had a zoonotic influenza, then obviously baloxavir may be appropriate. And I'll talk a little bit about oseltamivir and where that fits in a little bit more. Treatment should be administered as early as possible, and without going into all the detail, it's pretty clear that the antiviral therapies are most effective in the early phase of the disease. Next slide, please. Now, there are many, many recommendations, so I'm not going to go through all of them because we would be in for a very long presentation. I'm trying to focus on some of the more relevant ones. But I guess what you can see from this slide is we can see what the guideline group, based on work from COVID and from this guideline group, took as significant changes on from drugs. And you'll see on here what was relevant is that the time to alleviation of symptoms with baloxavir was more than a day based on the studies that were available. So people without taking baloxavir had about 5 days of symptoms. People that did take it had it less than 4 days. And you'll also see that the admission to hospital was 21 per 1,000 down to 5 per 1,000 with baloxavir. So you can see that was a very important findings for the guideline group as to why something like baloxavir was recommended as a treatment for influenza, because it was thought to reduce hospitalisation in patients with non-severe disease at high risk and also reduce the time of symptoms in patients. Next slide, please. And multiple antivirals went through this process, including, as mentioned, baloxavir. The panel didn't recommend baloxavir in the setting of non-severe influenza and in patients of low risk to progression of severe influenza. So those are patients that don't have the risk factors, are not over 65. It was not recommended the treatment in that situation. These are conditional recommendations. It's not a strong recommendation against. So again, this really encourages some clinician evaluation of the patient they're seeing. Next slide, please. This is obviously one of the more topical recommendations. So using the same processes was worked out for baloxavir, the panel actually felt there wasn't evidence for oseltamivir in non-severe seasonal influenza. So that's seasonal influenza in patients that are not hospitalised. There was not a recommendation for using oseltamivir based on the evidence that was available. Now you'll just see in the caveat there, there's a little, sorry, in the remark there, you'll see some of the explanation. And so the way the guideline is set out, and as I said at the start, some people will refer to the flowchart, they just need to see the information. But there's actually quite a lot of information available either in the PDF available online, or you can use a program called Magic App to look at the guideline, where you can go through the deliberations of the panel and the evidence behind the decisions that were come to. Next slide, please. And just a quick caveat as to why this was different to baloxavir. So you can see, without going into the detail of the evidence, that the time to alleviation of symptoms was less. It was about 0.7 of a day. And the panel had previously decided that 1 day was considered a patient-related outcome of reduction of symptoms. And you can see there's not the same reduction in hospitalisation with oseltamivir as there was with baloxavir. Next slide, please. I'll talk a little bit about, there is a little caveat with zoonotic infection that I'll come to when we talk about severe influenza in a minute. Now, this is an interesting recommendation, not because anyone hopefully will be surprised by this recommendation, but I think it's really important. So obviously one of the challenges, and as a practicing clinician, one of the challenges is the drive from patients, from the community, from your own clinical practice as to whether you should prescribe antibiotics. I'll talk a little bit about testing in a minute, but many places, including low, middle, and highly resourced settings, do not have access to influenza testing immediately available. So you see a patient with an influenza-like illness, and the question is, should I start antibiotics as well? And so there's very little evidence in this space. So we did rely a little bit on the clinician expertise, and hopefully no one is surprised by the recommendation that was come up with. But that is that in patients with suspected or confirmed non-severe influenza virus infection, so again, not hospitalised patients, and a low probability of bacterial co-infection, we recommend not administering antibiotics. Now, for I'm sure all the expert clinicians on the call, you would say that's a pretty obvious recommendation, but sometimes it is good to really make a panel sit down and think about what is commonly happening around the world and try and influence the use of antibiotics that are not required to give clinicians some confidence in not prescribing antibiotics in this exact scenario. Next slide, please. Now, I talked before about severe influenza and oseltamivir. This was really interesting, and I'll profess my bias. I'm an intensive care doctor. So I was actually quite surprised by the lack of evidence, and I'll talk about this later, in antivirals in severe disease. Now, there are observational studies. We limited our evidence search to randomized controlled trials. And I think we really are, this is a large call out for randomized controlled trials in this space, severe respiratory infections, including influenza, because we really do lack that high level evidence to make these informed decisions by. So based on really a lack of evidence and previous recommendations, we suggested administering oseltamivir in severe disease. You'll see it's in the recommendation there. It's very low quality evidence. It's a conditional recommendation, but we really have a paucity of options in this situation. And we're really hoping that when we update the guideline in the near future, there'll be more evidence in this space. And we know there are a number of trials going on around the world at the moment. Now, you'll just see at the bottom there, just a little caveat, as I mentioned before, which is important. This recommendation also applies to patients with novel influenza A virus infections associated with high mortality, zoonotic infections, even if the patient does not fulfill the criteria for severe influenza. So you'll notice there for patients with zoonotic infection, sometimes obviously they become very sick quite quickly. Oseltamivir obviously appropriate if that's when it's determined. But we also have options there for baloxavir or oseltamivir for non-severe zoonotic infection. Again, it's an area that requires some expertise. And as Tim rightly pointed out, early recognition and understanding is really important in that space. Next slide, please. Again, just to go over, we recognise this is quite a complicated recommendation because it really does lack evidence, again, surprising many people. So there's just a little bit more information there, which people can have a read of, recognising that we would love more evidence in this space for antiviral therapy of severe disease. Thinking back to Wenking's talk at the start, just demonstrating just how many people die each year around the world from influenza. Obviously, those people all have severe influenza, so we really need to look at our treatment options and see if we can do anything to help these patients. Next slide, please. This has been published now in JAMA, which is very exciting, and just a sort of congratulations. You'll see Tim's on that paper and the methodologists that work with us on this paper. So just to, I guess, recognize.
Looks like we lost Steve just momentarily. I can't see him, but while he is while he's indisposed, I'll just keep going. I think on the basis of his slides, Spria, you can put this slide back up. I think he was showing that the evidence for this guideline for severe influenza, and particularly the network meta-analysis, which allows comparisons of drugs that were not directly compared in randomized controlled trials or others, has been published here. And I think it's part of the transparency of the process that means that we have all the evidence that was available to the panel available to you and other researchers. Next slide, please. So apart from the medications that were given, and Steve has talked about those in various circumstances, and he's back to take back over. Steve, I was just about to start talking about adjunctive therapies, but you like steroids. Go back to you.
I don't know what happened. Sorry, the Australian internet let me down. That's happened to me before, but usually it's not too bad here. But anyway, I apologise. They did say there were some updates going on in my street a few weeks ago, so maybe that didn't go as well as planned. Again, apologies. Thanks, Jamie. So look, an area that, and just the last few minutes, this is quite a topical area, obviously. And again, probably lacking in the evidence we were hoping to be there. We suggest not administering steroids in patients with influenza. This is a really interesting area, and it's not the time probably to talk about the COVID recommendations, where obviously many people would know steroids had a strong positive influence on outcomes for patients. You'll notice the little caveat there. There is evidence in ARDS for steroids. So if you go to the next slide, you can see why the panel had some deliberate discussions around this. So without going into too much detail, on the left with the numbers there is the comparator, on the right is the intervention, which is steroids. So you can see with influenza, there's a pretty clear, from observational studies, that patients with steroids are a little bit worse with influenza. Very low quality of evidence or certainty of evidence, which is a key part of guideline writing, is, how certain are we about that evidence? You can see that was unadjusted. When it was adjusted, it got a little bit less, but there was still a significant difference, but low certainty of evidence between, and that patients with steroids did a bit worse. However, when you looked at ARDS, it's flipped. So in patients with ARDS, as people would know, acute respiratory distress syndrome in ICU, you can see that patients did a little bit better with steroids. Many of the people on the call, if not everyone, would know that's a final common pathway for many respiratory infections in intensive care. So how do you make sense of these recommendations? Our panel came down on not recommending corticosteroids, but again, really a shout out that we need more evidence in this space, especially coming on in the post-COVID period, or post-COVID severe infections that we had a few years ago. Next slide, please. There was recommendations against these therapies, which I think people would understand, really lacking in evidence, and what evidence was there really didn't demonstrate the benefit. And just in the last few minutes, next slide, please. Now, testing was quite interesting, and we did do some we were very fortunate to work with some excellent methodologists who looked at testing both for severe and non-severe. Just for today, in the interest of time, I thought I talked about severe testing, but there's also some point of care testing recommendations around non-severe in the guideline, which I'd encourage people to look at. So the question we looked at is, does testing make a difference? Now, obviously, this relates to whether you have treatments that make a difference, or is there other motives that may benefit, such as prevention of disease in other people, for example. So we've suggested using high sensitivity and high specificity tests, such as NAT testing or PCR, for the diagnosis of influenza and severe disease, and then treating patients who are positive with an antiviral agent, which in the setting of severe disease was oseltamivir, if you remember from before. You'll see there what to do if the results are going to be delayed for more than 24 hours, and that is a very common scenario around the world if testing is available at all. Next slide, please. And just a little insight into some of the methodology and the information that we provide in the guideline. So you can see here that, what is the options of appropriate treatment? That's the green section. Appropriate treating of influenza. The hashed green is appropriate treatment of no influenza. And the option of PCR and treating got the highest number of people with the appropriate treatment. And that testing was also very high. But for example, the option of treating everybody in a disease which might be influenza meant a lot of people got treatment inappropriately. So again, recognising the resource limitations, it does suggest that being able to offer testing of patients with severe influenza-like illnesses would have some benefit. And just in the last couple of minutes, next slide, please. Just a really important section, obviously, is the persons exposed to influenza. Again, we have the flow chart there, and I've taken some section out and blown it out for people. But really you're looking at which patients would benefit if we know they've been exposed to a patient with influenza from very early treatment or prophylaxis. So within 48 hours of exposure, before developing symptoms, because obviously at the point of developing symptoms, you have the disease. What would be the various treatment options? You can see oseltamivir, zanamivir, lenamivir, and baloxavir are all there as treatment options. There is 2 recommendations for seasonal and zoonotic, with slightly different criteria in terms of severity. Really seasonal being recommended for those patients at extreme risk, which, if you remember from the start of my talk, was 85, or severe or multiple risk factors, so that patients, which we leave to some clinician discretion, but I think as clinicians, everyone can determine what those patients are. Next slide, please. So again, with seasonal influenza, as you can see here, this baloxavir was the recommendation 4. So just highlighting that again, it doesn't replace influenza vaccination, really important. That's, and I think just an obvious thing to state, but really important for clinicians to highlight to high-risk patients. They really need to have their vaccinations up to date. And extremely high-risk patients are over 85, or those with multiple risk factors. And they're the patients we would think about administering a prophylaxis or a treatment before they develop symptoms. Next slide, please. And for zoonotic, again, I picked oseltamivir. I could have picked one of the other treatments in this. So in this situation, we suggest treating people that are exposed with prophylaxis. So not so much linked to the patient themselves risk factors. This is really the risk factor of the disease. So if you're exposed to what is potentially or likely to be a high mortality influenza virus, a novel influenza virus, then we would suggest early treatment. And there's a little bit more detail there in the remarks as well. And conscious of time, I'll just finish off with the last couple of things, which recognising there's a lot of expertise on the call. Next slide, please. So some research questions. Really, there's nothing like a guideline to make you recognise and become a little bit humble about how much evidence and information there isn't available. I think I've highlighted in this talk that really we need some high quality studies around antivirals and immunomodulatory therapy in severe disease. We saw in COVID that we were able to make a difference with some high quality therapies and some high quality research. And I guess it's really a shout out in seasonal influenza for those things to be occurring. We know they are happening at the moment, but we'd also like to see them happening in all resource settings, not just in high income countries, but across the world, where we can see the impact of these treatments on patients. Next slide, please. And similar for novel influenza, recognising the challenges of research in that these are sporadic infections, for want of a better word. Hard to do those, obviously, those big clinical trials in, but really keeping, a high track of data so we can look for other therapies and we can see what we can do best for these patients if and when highly lethal disease appears. And next slide. Thank you very much for your time. Back to you, Jane. And again, apologies for the internet failing.
Thank you very much, Steve, for that very comprehensive and very clear explanation of the recommendations. And there are lots of questions. So I invite Jamie to take over once again and moderate the Q&A session. Jamie, over to you.
Thanks, Supriya. You mentioned, I think, one of the comments is that antivirals are recommended for people who are exposed to influenza, but you mentioned that antivirals don't affect the outcomes for non-severe influenza. Do you want to just talk a bit about those, the guidelines as describing for prevention of influenza in those that are exposed to it?
Yes, and I recognise, and I thought long and hard about the best order to present these in, because when you try and present them in order, there is some tricky advice to work through. So thank you for the question. I think what the guideline group came down on is that for non-severe influenza, there was really only a signal for baloxavir, that there was a reduction in the symptom time for patients from 5 days to 4 days. And for patients at a high risk of developing severe disease, a reduction in hospitalisation. It didn't actually translate to mortality, but it did show a reduction in hospitalisation, which was felt to be a very important patient-related outcome. So we know that early treatment in non-severe disease with baloxavir would reduce hospitalisation. In some ways, we're not talking about prophylaxis of people, obviously, that we don't know have been exposed, but in situations where we know someone has been exposed to influenza before they've developed symptoms, so presumably in the very early phase of the disease, the chance of everyone being exposed to influenza is not 100%, obviously. So, and I'll leave that to people with more expertise to talk more about that exactly. But we know that early treatment in that situation can reduce the risk of patients developing influenza. And then by extrapolation, obviously, they reduce their risk of hospitalisation. And it was felt by the panel that those patients at extremely high risk would benefit from that early treatment. That being patients over 85 years old, or as mentioned before, had one extreme risk factor or multiple risk factors that were high risk. So an example might be someone with maybe not 85 years old, but may have severe cardio and respiratory disease. And a clinician would say this person is at extremely high risk of developing severe disease if they develop influenza, hence suggesting treatment with one of the antivirals. Why do these work in that situation and not in others? Again, probably a bit beyond my expertise, but the theory being that really early treatment in that situation, the antiviral's impact is probably different than it is later in the course. Thanks, Joe.
Thanks. I'm just going to come to you and then I think to Janet. And it's related to the same question, a comment that your requirement or suggestion that the antivirals need to be given within the first 48 hours of infection should be quite early for many healthcare systems and for many patients in many healthcare systems. How do you square that? And then maybe come to Janet and just ask Janet to talk about the availability of diagnostics and how we negotiate that and improve access to diagnostics. So Steve?
Yeah, I'll leave it to Janet, who's got such extensive experience in this, but I think it does come down to trying to balance the recognition of resources available in the world, versus trying to motivate and inspire jurisdictions and governments to invest where possible in things that would make a difference for patient outcomes, such as testing and access to antivirals, which we know there's significant inequity around the world. But I'll let Janet explain that better than me, I'm sure.
Thanks, Jamie and Steve. I would agree. I think we have to look at the clinical care pathway. So whenever we're dealing with, an infectious disease with epidemic, pandemic potential, the importance of one, rapid clinical identification is key, right? The second, applying appropriate infection prevention controls. And I know someone had written a comment about that. And then testing. Right. So the package of early recognition, early IPC to prevent onward transmission, as well as early testing, which helps both with, the pathways, infection prevention control measures, as well as the pathways treatment intervention. So then can we give the right treatment to this patient if we have the known pathogen? And for some pathogens, like COVID, potentially our evidence base and treatment recommendations are much stronger because the evidence generated during COVID was a lot. So we are pretty clear on which antivirals were the most effective for non-severe patients. We're pretty clear on the use of corticosteroids for severe patients. Whereas in influenza, I feel we're not so clear, like we still need more data. We need more work done on R&D pipeline drugs in order to be more targeted with which drug we would use at which point in time of the disease. And of course, access to early diagnostics to get people on that that care pathway is very important. But you'll see the benefit in patient outcome if we knew there was a more effective intervention at that time. Thanks, over.
Thanks, Janet. I'm just going to put one more, I think, to Steve, and then one to Wenxing. So Steve, talking about the use of antibiotics and secondary bacterial infection subsequent to influenza virus infection, do we know a rate, or how are you using the probability of a superadded bacterial infection to guide the use or not of antibiotics, where the primary diagnosis is flu?
Yeah, that's a good question, it's probably one of the areas that the science was lacking a little bit. So we know the risk factors for severe disease, but it wasn't as robust, especially at the time of writing the guideline, as maybe. So we used a cutoff of sort of 30% of what would be considered a likelihood. Now, obviously, using that as a continuum sort of scale, if, for example, a clinician, and I'll use my line of work, intensive care, for example, had a patient that had influenza for quite a while and they developed maybe a secondary respiratory illness and they had a lobar pneumonia on their chest x-ray and they were coughing up a dark sputum, a clinician might think, I think this is likely to be a secondary infection, a bacterial infection. It's a clinical scenario different to the early development of influenza. At the other end of the spectrum is someone who comes in to a clinic with a classic influenza-like illness. No signs this is a bacterial infection. As Wenxing said before, there's millions of people presenting like this every year around the world. And they're the sort of patients that this recommendation would suggest that antibiotics offer no benefit in that situation. So patients that the likely diagnosis is influenza, recognizing there is a grey area in the middle. And I think that's where things such as early testing could really make a difference moving forward into the future. But the panel did feel very strongly that for patients in that low likelihood of bacterial infection, antibiotics had no benefit in that situation. Thanks, John.
Thanks. And it's one to Wenxing. I think people are asking specifically about Northern and Southern Hemisphere when we're talking about this, and particularly about influenza, seasonal influenza, the different patterns that are seen, and really what's meant by Southern Hemisphere in terms of the patterns that we might expect for seasonal flu. I wonder whether you might just talk to that for a moment.
Sure. So yes, Southern Hemisphere means where countries have the Southern Hemisphere epidemic patterns of those. Because I said that flu viruses really are changing. So what contained in the vaccines for use in that season need to be as closely as possible for the virus circulating there. For that reason, WHO will update the component specifically for the vaccines for use in Southern Hemisphere and specifically for use in the Northern Hemisphere. That meant by the Northern Hemisphere vaccines and the Southern Hemisphere vaccines. Just also to add a comment on the bacterial, secondary bacterial infection. So WHO, we've been helping countries to understand the disease burden. And at the moment, we're only doing those respiratory deaths, for example. So there's still work going on to model with regards the other causative reasons like the cardiovascular diseases, etc., the burden of that. So the work is still going on. Actually, one value of vaccination is also supposed to reduce the use of antimicrobials, although the exact measure with regards to what is the percentage is not yet obtained so far. Back to you, Jenny.
Thanks. Supriya is telling me we're out of time, so thank you for all your questions. We'll try and answer some more of those if we haven't already in the Q&A. And as Supriya said, the recording will be available afterwards. So I think back to Janet to close the meeting.
Thanks, Jamie. And I will briefly just say a big word of thanks to all the participants, for all of you who've been here. It looks like we've had about 600 plus participants today. So thank you so much for joining us on this webinar series. Thanks to the EPI-WIN and the Project ECHO support for this webinar. Thanks to our speakers, to Dr. Tim Uyeki and Dr. Steve McLaughlin, and for Jamie for moderating the very important Q&A discussion, and for my colleague Wenjing Zhang here at WHO also for being with us here to give us the global perspectives on the influenza program. I think what we've learned is there's more to do. We can still drive down mortality and morbidity with finding improving our therapeutic regimens for influenza virus infection. So this is a call out to continue to enhance the R&D pipeline for influenza virus. It's a call out to continue to do good clinical research, efficient, large-scale studies, so that we can find, the best treatment options for our patients. And also, although we focused here a lot on medicines, meaning therapeutics, antivirals, immunomodulators, but also the importance in managing patients, which is not the topic of today, but hopefully in the future, of good supportive care of those patients who develop severe disease, the use of oxygen, the use of respiratory support interventions. And we do plan to update our guidelines on those types of clinical interventions around supportive care, the use of respiratory support, BiPAP, CPAP, invasive ventilation for patients with severe influenza infection, also with severe acute respiratory infections from other viruses with epidemic and pandemic potential, because we do know that package of care is important, and that supportive care element is if not more so as important. So more to come in that area, but a big thanks on behalf of WHO Health Emergencies Program for your attendance, and we look forward to seeing you again soon. So thank you. Back to you, Supriya.
Thanks so much, Janet. Supriya had to step out, so I will be closing on behalf of EPI-WIN. I'll wrap up by saying thank you very much to all of our speakers today, the WHO colleagues who have worked on this, and the EPI-WIN team. Finally, thank you to the audience, to all of you for coming and for your questions. The recording of the webinar will be available at the EPI-WIN website. EPI-WIN Digest, a slide set with key messages on this topic, will be published shortly. If you want to keep updated on future EPI-WIN webinars, recordings, and presentations, and the EPI-WIN Digests, please subscribe to our mailing list. Both links will be appearing in the chat. And finally, we hope you'll be joining us for our next webinar next Tuesday, October 29th, on home care and IPC measures for communities in the Mpox public health emergency response. Details are posted on the website and will be sent to the mailing list. Thank you again and goodbye. See you next time.